So thank you very much, everyone, for joining us. Today we'll talk about rapid sequence induction. Can we make it safe? We know that RSI intubation is a fraught with hazards and risks to our patients and for the health practitioners as well at the same time. And hopefully I'll take you through a journey where by the end of this talk, we will have a significant impact on our RSI technique. The National Audit Project 4 report, which was published in March 2011, will be the starting point for me. It reported major complications of airway management in the United Kingdom. I think without doubt it has been the most significant report in the last decade, which impacted significantly on the airway management in England. I'll start by sharing a few messages from this report before we go through the objectives of our talk. One of the major findings of this report was that aspiration was the most frequent cause of airway-related mortality, and goes without saying, anything that reduces this complication would impact positively on patient outcome. It also found 1 out of 5 of all airway incidents occurred in the ICU. Unfortunately, 50% of them led to death, and 11% of them led to sustained neurological damage. Compare that to only 14% inside the OR, which led to either death or neurological damage. So unfortunately, airway incidents inside the ICU are bad news. Another major outcome of this report was the lack of capnography contributed to 3/4 of deaths inside the ICU. Moving on to our objectives, we'll try to establish what is the rapid sequence induction, what to do before you embark on RSI, what are the indications for RSI, what are the steps related to RSI, what do we really mean by modified RSI. Then I will share you one of the great articles that I found preparing this talk, which dealt with intubation bundle. Then hopefully we'll have a few slides about the way forward. So what's RSI? It was first described in 1961 by Sellick, the same guy who invented or proposed the cricoid pressure. I will talk about it later on. RSI is a process for quickly securing an airway in patients who are at risk of aspiration. Just as simple. You need to secure the airway quickly, so you have to use the RSI. And the major anesthesia textbooks suggest that you use RSI in all patients who are at risk or at high risk of pulmonary aspiration of gastric content. So anyone at high risk of gastric aspiration is an indication for RSI. But who's at high risk of gastric aspiration? I'll share with you this list, but the list is bigger than that in different textbooks. Patients with full stomach, i.e. those who have not been fasting for more than 8 hours, trauma patients, intra-abdominal pathology like intestinal obstruction, inflammation, gastric paresis due to drugs or disease, esophageal diseases, pregnant ladies, obese patients, and if you are uncertain about intake of food or drink, then you should assume that your patient is at high risk of gastric aspiration. All these patients must have RSI if they needed intubation. However, before you go ahead and intubate your patient using RSI, you need to make sure that your patient does not have a difficult airway, because if they do, then you must consider your backup plans or even consider awake intubation. But what is difficult intubation? I found this article from 1996, which is a German article. Luckily, I found a translation version of it. And they came with this definition. Definition of difficult intubation is a trained anesthesiologist would need more than 3 attempts or more than 10 minutes for successful intubation. It also reported that difficult intubation incidence is 1 to 18%, and there's so many factors which contribute to this. But luckily for us and for our patients, cannot ventilate, cannot intubate situation is only encountered in 2 out of 10,000 to 1 in a million cases. Another definition from the American Society of Anesthesiologists defines difficult intubation as the clinical situation in which a conventionally trained anesthesiologist experiences difficulty with face mask ventilation of upper airway, difficulty with tracheal intubation, or both. As you can see from the 2 definitions, you only know about difficult intubation after it happened. But is there any ways to predict difficult intubation before you get into this hairy situation? Well, I'll share with you this study from St. Michael's Hospital, which was published a long time ago, where they studied 18,500 patients over 27 months, and it was a pre-operative airway examination where they looked at the mouth opening, the neck mobility, the thyromental distance, and the visualization of the hypopharynx. And they defined difficult intubation as more than 2 laryngoscopies. And they found significant increase in the relative risk of the incidence of difficult intubation if there was reduced mouth opening, reduced thyromental distance, reduced neck mobility, or if there was a presence of more than 3 abnormalities. Another way of predicting difficult airways is by the Lemon assessment. L stands for look externally for any deformities that might make you think this is going to be difficult intubation. For example, prominent upper incisors, micrognathia. Evaluate 332, which is the first 3 stands for mouth opening more or equal to 3 fingers, chin hyoid distance equal or more than 3 fingers, thyroid to mouth floor more than 2 fingers. Modified Mallampati score, and you need to be mindful of those with a grade 3 and 4. I'll show you that in a minute. Obstruction if there is any blood or vomitus inside the mouth. And finally, the neck mobility. If your patient has got restricted neck mobility, then it will be difficult for you to get them in the right position to facilitate intubation. What is modified Mallampati score? Well, it's just direct visualization of the patient's mouth. You ask your patient to open wide and stick their tongue out and see how much of the oral cavity you can see. Grade 3, you can see the soft palate and the base of the uvula only. Grade 4, you can see the hard palate only. So those grade 3 and 4 are the ones who you should be worried about. But unfortunately, modified Mallampati score in a meta-analysis didn't perform well. The area under the curve for it, if you use it alone, was not that great. And the authors of this article concluded that our assessment shows that the modified Mallampati score is inadequate as a standalone test of a difficulty laryngoscopy or tracheal intubation, but it may well be a part of multivariate model for the prediction of difficult tracheal intubation. Another score which was proposed in the last few years, Makocha score. And here they divided the points into patient-related factors, factors related to pathology, factor related to operator. And they gave very high score for Mallampati score of 3 or 4. Obstructive sleep apnea received 2 points, and the rest of factors received 1 point each. And you can see clearly from here that straight away our patients in ICU would score at least 3 or 4. The fact they put a lot of weight on Mallampati probably compromised the validity of this score, as we will see. They said if your patient scores less than 2 to 3, then or less, then the risk of difficult intubation is very low. But once you got to a score of 4 and 5, then the incidence of difficult intubation gets around 30%. And that's where the higher the score is. However, the negative predictive value for this test has been found to be very high at 98%. But look at that positive predictive value. It's very low at 36%. What does that tell us? If your patient has low score, then you can be certain that the intubation is going to be easy. However, if the score is high, unfortunately, that doesn't necessarily mean that your patient is going to be a difficult intubation. I guess it's good to have it in mind and to be well prepared ahead of time. And I think using combination of these predictive scores will enhance your ability of recognizing the difficult intubation before you embark on intubation. Moving on now, what's RSI? There is no consensus about what's RSI, but I found these steps to be the ones that there's kind of agreement about them: pre-oxygenation, medication, positioning of the patient for intubation, the intubation process, the confirmation of the endotracheal tube, and then post-intubation care. In my talk, I'll focus on the first 3 steps because I think they are the major contributing factors to any complication. We'll start with pre-oxygenation. And the aim of pre-oxygenation is to increase the apnea window. Basically, you want to increase the period after you give your patient the induction agent and you get your patient into apnea. And the method is by administering 100% of oxygen for 3 to 5 minutes prior to induction. And you are hoping by giving the 100% oxygen, you denitrogenize the lungs and create an alveolar oxygen reservoir. Remember this, alveolar oxygen reservoir is your savior. The higher the alveolar oxygen reservoir, the longer the period that you can have for intubating your patient before they desaturate. Now, we know that 3 minutes tidal ventilation with high flow oxygen using a tight fitted mask is the orthodox or traditional way of teaching RSI, and you make sure you don't use the non-rebreather mask. Instead of that, you must always use tight fitted mask, preferably connected to a PEEP valve. New evidence now emerging that positioning the patient head up in 20 degrees will lead to reduction in the basal atelectasis, and they suggest that during pre-oxygenation, you put the patient head up. However, if you are dealing with an obese patient and you have already got them into the right position for intubation, then you can tilt the whole bed or table in the reverse Trendelenburg. As we said, this will increase your alveolar reservoir. The other thing that has been introduced recently to prolong the apnea period is to give oxygen via nasal cannula at 15 liters per minute. And here we are talking about simple, ordinary nasal cannula, not the fancy high-flow nasal cannula. We are talking about the simple, ordinary nasal cannula, and you dial the oxygen from the wall to the maximum. This will provide to you even higher than 15 liters per minute. Studies have showed that this will add extra 3 minutes before desaturation below 95. So you already gained 3 minutes and your patient saturation is still maintained above 95. In a Thrive study, they prolonged the apnea period for more than 15 minutes. And the worry was at that time about CO2 rise rather than about oxygenation. To that extent, giving high flow oxygen during the apnea period will prolong your apnea window. And I'll share with you this meta-analysis there's a couple of meta-analysis done on the apneic oxygenation. This was done on ICU patients. They reviewed 6 studies, which enrolled almost 520 ICU patients. And what they found was apneic oxygenation group had higher oxygen saturation readings, and the incidence of critical desaturation, i.e. oxygen saturation less than 80%, was significantly higher in the control groups, i.e. those who didn't have apneic oxygenation. And I strongly recommend this article for trainees because it dealt with the matter thoroughly. Moving on to position for RSI. We know there is the usual teaching, the morning sniffing position, by which you flex the neck and then extend the head at the atlanto-occipital junction. And the aim of this is to align the 3 axes, the oral axis, the laryngeal axis, and the pharyngeal axis. When you do head elevation, i.e. flexion, then you align the pharyngeal and the laryngeal axis. And when you do the extension at the atlanto-occipital junction, then you align the 3 axes together, and you can facilitate intubation. The neck flexion is usually at 35 degrees, and the head extension at 15 degrees. And I found this Popitz pillow demonstrate the exact, if you like, dimension that you need to put the head in. So you can see clearly that the patient's neck should be higher than the distance for the occipital part of the head. The other position that has been recommended only for obese patients, and I emphasize the obese patients, is the ramp position, or the rapid airway management position. We know lying the obese patients flat, because of the massive increase in the anteroposterior diameter, the sternal notch or sternal angle would not be at the same level as the as you can see clearly in this picture. And to get the external auditory meatus at the level of the sternal angle, you should put a stack of pillows or blankets under the upper part of the patient body and the shoulders to get the external auditory meatus at the level of the sternal angle. You can also use, if you like, ready-made pillows for that purpose. These pillows are commonly seen or used in centers where they do a lot of bariatric surgeries. What is modified RSI? To be quite honest with you, before I prepared this talk, I did have an idea about modified RSI, but I realized there's no consensus about what is modified RSI after I reviewed the topic. And I'll share with you this interesting survey from the USA. 490 surveys were received from 58 institutes, which represented 44% response rate, and they were trying to see what modified rapid sequence induction means. And they found, based on our survey, we have been able to construct a meaningful definition of modified RSI, which includes the use of oxygen administration, but we know this is also an integral part of the classical or traditional rapid sequence induction. The application of cricoid pressure, again, this is an integral part of the classical or traditional rapid sequence induction, and an attempt to ventilate the lungs via positive pressure ventilation before securing the airway with a cuffed tracheal tube. In my opinion, this is the major difference between the traditional, or if you like, classical rapid sequence induction and the modified rapid sequence induction. Some colleagues, before I reviewed the talk, used to say, well, RSI, you use muscle relaxant. Modified, you don't use muscle relaxant. but clearly this survey didn't suggest that. When to consider modified RSI in two circumstances. If your patient is desaturating during the apneic period, then probably you're allowed to give them bag valve mask ventilation, or if your patient is obese. It's the recommendation that you give a few breaths, so you go slow and low. You give them also low tidal volumes. This maneuver will lead to alveolar recruitment and improves your patient's oxygenation prior to intubation. Tips for pre-oxygenating the obese patients. So always try to pre-oxygenate them with the head up or using the reverse Vandenberg position. Try to use adjunct airways like nasopharyngeal airways or oropharyngeal airways. Having two operators will facilitate the bag valve mask maneuver, and try to have PEEP because these patients have, if you like, heavy weight of fat on their chest, and they de-recruit their lungs quickly and lose their FRC. In addition to that, try always to use nasal cannula at 15 liters per minute during the pre-oxygenation period. What about cricoid force or pressure? As we said earlier, it was introduced by Sellick a long time ago. The aim of it was to minimize passive regurgitation of gastric contents. It must be applied before the loss of consciousness. So you talk to your patient and you explain to them, you'll feel me pressing on your, or obviously the assistant of the intubator will say, you'll feel me pressing in your neck as you are drifting to sleep. And you should compress the esophagus between the cricoid cartilage and the C5, C6. Force applied is 30 to 40 newtons, which equals to 3 kgs. As you can see, it's really difficult to get this right. And in England, they have special courses for the, they call them ODAs, the practitioners that help the anesthetists in the operating room. And still, they don't get it right all the time. You have or must remove cricoid pressure only after tracheal intubation is secured, and also pressure must be released during active vomiting. We know that cricoid force or pressure does not prevent forceful vomiting, and if you put the pressure on, you might harm the patient by causing esophageal rupture. Is there really strong evidence behind cricoid pressure? I found this review article very helpful, and they concluded that cricoid pressure introduced on limited evidence base. Properly applied cricoid pressure probably is effective. More RCT is required to confirm this. And the NAB4, one of its conclusions found that in the United States of America, those lawsuits where they had complication or aspiration complication during intubation, those cases who applied cricoid pressure got lower reward or compensation compared to those who didn't have cricoid pressure applied to them. So really the jury's still out on cricoid pressure, it seems to be. Moving on to the RSI medications. And we use 3 groups of medications. We have to use opioids, we have to use sedating agents, and we have to use muscle relaxants. The commonly used opioids in ICU is fentanyl. We give it at 2 to 6 micrograms per kg. Ideally, you should give it 2 to 3 minutes prior to intubation, because the onset of action for fentanyl, it's around 3 to 4 minutes after administration. You can use morphine at a dose of 5 to 10 milligrams or alfentanil. The beauty of alfentanil is that it induces apnea, but fentanyl and morphine, they don't tend to do that unless you give really high dose. The other group of medications that we use is sedating agents. Traditionally, thiopental used to be used for RSI, but because of its safety profile, people people moved away from it to propofol, and the usual dose is 1 to 2 milligrams per kg. The younger the patient, the higher the dose you need to sedate them. Midazolam can be used, and probably the only advantage I can see for midazolam, if you use adequate dose of it, it will give you a longer period of sedation compared to propofol. Etomidate is commonly used in those with hemodynamic compromise, especially in ER. They like it, but there has been a lot of concern about its effect on the adrenal glands. Ketamine at 2 milligram per kg is a great drug in hemodynamically compromised patients, and also you can use it for delayed sequence induction. And what we mean by that, if you have someone who is quite hypoxemic and agitated and you are unable to pre-oxygenate them, then it's quite plausible to give them ketamine, which induces dissociative anesthesia state, so the patient will maintain his tidal ventilation and he will be calm and tolerating the mask on their face to facilitate pre-oxygenation. Usually this takes a few minutes, and that's why we call it delayed sequence induction. It's also good in patients with asthma attack prior to intubation. It has the effect of bronchodilation as well as not affecting their hemodynamics. The third group of drugs that we must use during RSIs is muscle relaxants. Two drugs are commonly used, dexamethasone and rocuronium. Both of them, they have a very rapid onset of action, especially if you use the higher dose. The concern about hyperkalemia with dexamethasone is not really genuine unless your patient has got significant hyperkalemia before you give them this drugs. Neuromuscular blocker for intubation has been in use for a long time. It was introduced in 1942 to aid tracheal intubation. And I found so many studies tackling this issue, but I was really pleased to see this Cochrane review, which was published last year, which reviewed 34 trials. 4 of them were low bias, and I'm going to share with you the results of these 4 low bias trials only. Basically, they compared the avoidance of neuromuscular blockers with non-avoidance, and they looked at the incidence of difficult tracheal intubation, and you can see clearly that the use of neuromuscular blockers reduced the incidence of difficult intubation, and they concluded avoidance of neuromuscular blockers leads to 13 times increase in difficult tracheal intubation, with very, very significant p-value. One randomized controlled trial I thought I'll share with you, which was double-blinded, recruited 300 patients, and they compared propofol, alpentylene, and saline against propofol, alpentylene, and rocuronium. And they were looking for the post-intubation symptoms as well as the ease of intubation. And as you can see, there's significant reduction in the incidence of difficult intubation as well as the post-intubation symptoms. And if you want to see what the guidelines say, Difficult Airway Society 2015 guidelines from the United Kingdom emphasized the importance of neuromuscular blockers to reduce or to minimize the incidence of difficult intubation. So, moving forward, we're nearly done. Back to the NAP4 report. And they suggested that an intubation checklist should be developed and used for all intubations of critically ill patients. A checklist might usefully identify preparation of patient, equipment, drugs, and team. A checklist should include identification of backup plans. And if you browse the internet, you'll find a lot of checklists being used. But I will share with you this checklist, which was published recently, actually February this year. And here you can see they categorized it into 4 columns: prepare the patient, prepare the equipment, prepare the team, and prepare for difficulty. And the idea behind checklist: before you embark on intubation, the intubator must go through all the items and check it with his team to make sure things are absolutely ready for the intubation. And most importantly, you must verbalize the airway plan. So you'll say, plan A, I'll go ahead, give drugs and do laryngoscopy. Then if that fails, then I'll move on to plan B and C, and you verbalize that to your team. At KFSH, we have proposed a similar checklist. I've been working on this for the last few months, so I didn't see the checklist I shared with you earlier, but I was so pleased to see we covered most of it. The intubation bundle. I found this article is quite fascinating. It says a two-phase prospective multi-center controlled study, and they introduced 10 components for each intubation, and they compared pre and post introduction of these components. Briefly, they pre-oxygenate with the use of non-invasive ventilation. They always have 2 operators for intubation. They always deployed RSI as a way of intubating patients. Cricoid pressure was applied. Capnography, protective ventilation. Fluid loading also was given to all patients. Preparation and early administration of sedatives, as well as vasopressors as needed. And they found significant reduction in life-threatening complications as well as other complications. So to conclude, most ICU patients require RSI for intubation. But before you do RSI, make sure you assess your patient for the possibility of difficult intubation. Lemon assessment is quite a useful tool. Pre-oxygenate your patient head up. Don't pre-oxygenate your patient using non-rebreather mask. Instead of that, you must always use tight-fitted mask, preferably with a PEEP valve, and always apply nasal cannula at 15 liters per minute. If your patient is lean, then morning sniffing position is the way to go. However, if your patient is obese, then you must ramp them to facilitate the intubation. And by the way, ramping non-obese patients found to increase the incidence of difficult intubation. So only use ramp position for obese patients. Always use neuromuscular blockers, and introduce a checklist to your practice for intubation if you don't have that already. So, on top of checklists, always use nasal cannula for pre-oxygenation, pre-oxygenate in semi-sitting position. Always use neuromuscular blockers, and ensure you have plan B and C, and your team is aware of that. And remember to always have exit strategy, and that no one is big enough for airway, so seek help early on. With this, I'll stop and take any questions. Thank you very much.
Thank you very much, Hasan. Very, very straightforward, enlightening presentation. I should admit that I'm one of the physicians who are reluctant to use muscle blockers, actually. What I do is start with the fentanyl and propofol, and then decide whether I want to use muscular blocker agent or not. Maybe we should change that, and we should use it because it's really based on the data that you're presenting, it makes intubation much easier. Now, my question to you is, did you come across any studies that looking at high flow nasal cannula for pre-oxygenations to increase the apnea time for those patients compared to the regular nasal cannula of 15 liters per minute?
Indeed, thank you very much, Mazen, for that. Indeed, there's a couple of studies that utilized the high-flow nasal cannula, but I must say it's quite awkward. The high-flow nasal cannula, the fancy one, is really difficult to achieve seal with it. So if you apply the nasal cannula, the high-flow nasal cannula, then you put the face mask on top of it, then you might not get the adequate seal that you would like to see compared to the ordinary nasal cannula. But the studies initially were done actually on the high-flow nasal cannula, the true high-flow nasal cannulas. You're right.
I see that one of the audience just posted the same question here in the chat section, seeking your thoughts about high-flow nasal cannula, and you already answered that.
And really, high-flow nasal cannula might not be available to everyone, so really you don't need to. The dial on the wall tells you that you can dial up to 15 liters per minute, but actually if you carry on dialing it, it can reach up to 30 liters per minute. So you can effectively get a true high-flow nasal cannula if you dial the oxygen to the maximum.
Yeah. Go ahead, Nabil. Nabil has a question also.
Yeah, sure.
Hey, Assalamu alaikum, Hasan.
Salam, hi, Nabil.
Nice presentation. I wanted to comment maybe on a situation we face many times. Now in the ICU, many patients we intubate, they go through the stage, they come in on hypoxic, you put them on high flow, they may fail, and then they go to non-invasive, and then we decide to intubate. And so in those scenarios, your patient's already on one of those devices when you decide to intubate them, in comparison to what happened in the ED where patient comes in and get intubated quickly or right off the bat. So what do you suggest we do in those situations?
Well, absolutely. We face this many times, especially with the hemato-oncology patients. I guess you need to maximize the delivery of oxygen beforehand. Probably apply non-invasive ventilation or keep it applied to the patient that's already in use. The only caveat to utilization of non-invasive ventilation for pre-oxygenation is really if your patient vomited, then that can be a disastrous thing to happen. But the evidence is there actually to support using an IV as a tool for pre-oxygenation. In addition, if you add to it the high-flow nasal cannula, I guess you are maximizing the chances. But unfortunately, you must just optimize your patient as much as you can. But you have no option other than just go ahead and do it as quickly as possible.
Thank you, Hasan. Yasser Muhammad is asking, do you recommend positive pressure ventilation for all patients for pre-RSI?
Well, this is what's been proposed only for obese patients or those patients who are desaturating on you during the apnea period. We know that giving, if you like, positive pressure ventilation to these patients might insufflate air into their stomach, and that can lead to, unfortunately, aspiration of gastric content. So you only use it, as we said, well, that's what we mean by modified RSI for those who are desaturating on you during the apnea period and in obese patients.
Excellent. Thank you, Hasan. Dr. Abdulrazak Shakaki, I think he's a physiologist, is asking a question: would you use video laryngoscopy as compared to direct laryngoscopy, as some studies have showed better intubation rates for those patients? And he's just correcting me. He's an ICU physician at Wayne State University in Detroit.
Okay.
Thank you.
I think what you should use is the thing that you are familiar with most. There's conflicting messages coming out. Some people stating that video laryngoscopy is better than direct laryngoscopy, and others stating the opposite. I must admit I didn't go through the evidence thoroughly, but myself, I don't like using the video laryngoscopy. I try to avoid it if I can.
Maybe you have a different position there.
I think I've been trying, since this is the fashion now, to use a video laryngoscopy. And it's one of those things that you see, but you can't pass it. So sometimes we have more difficulty passing the tube, despite seeing the airways very clearly. We don't see that difficulty when we do direct laryngoscopy. So,
Indeed.
But I'm trying to get used more to the video laryngoscopy being the new methods. But I think each one of us will have to find a way that manipulating the tube is the tricky part of it. And so it's really not easier. It's a matter of experience and using one method over the other.
Well, I may actually disagree with that. Since I started using video laryngoscopy, I think I feel more comfortable in managing the airways. Dr. Abdul Razak is sharing. I'm just trying to see if I can give you. Abdul Razak, you can speak now to tell us about your experience.
Hello, you hear me?
Yes, we hear you. Go ahead.
Sorry, I was in the public library.
No problem.
Now I stepped out.
Okay.
Basically, I'm a current third year now in my fellowship. I'm about to graduate now in a month. So I have really humble experience to all of you. I appreciate the talk and the presentation. The way they put it as a standard of care now is to use video laryngoscope, but we face most of the difficulties when we are dealing with a lot of secretions or GI bleeders. Otherwise, we feel all of us are, like, among our faculties and fellows, more comfortable with a video laryngoscope. Even anesthesia team, they start with it first unless there is significant secretions or active vomiting or bleeding. Thank you.
Thank you very much. Say hi to Dr. Subani and the rest of our colleagues at Wayne State University over there.
I will,
my
for sure.
son just graduated from Wayne State University, and my daughter is there. So if you come across her, please take care of her.
For sure, Dr. Mazen. Thank you.
Shukran. Okay, any other questions we have from the audience? Let me just check again. I lost. Okay. I don't have any other questions from the audience. Gary, do you want to share your experience with us? You have the mic. It's always great to see you on our webinars, Gary. Looking forward to work with you again.
Yes, hi, Mazen. Thank you very much for the opportunity. When we were talking about, first of all, Hasan, your presentation was excellent and very much to the point. The one thing I was going to say, we often face patients who are hypotensive, and so we don't use much propofol for RSI. We tend to use more ketamine and high-dose rocuronium. We find in that combination they stay hemodynamically more stable. The other thing is we do often give some fluid prior to intubation, and either phenylephrine or push-dose epi, just to make sure that once you get the tube in, the patients don't go hypotensive. So I'm not sure what your experience is, but that seems to be what we tend to do.
I do agree with you. What about Hasan? What do you think about what Gary is saying?
Yeah, no, excellent. That's what we tend to do as well. And actually, one of the studies was done on ketofol. So they had the combination of propofol and ketamine in one ampoule, and you give it to your patients. So this is a well-known practice, and as I said, it's quite a good drug. It's a good drug for those patients who are hypotensive or unstable, and really it gives you ample time to pre-oxygenate them as well. I like ketamine a lot, and I think it's underused in the ICU world.
Very good. Gary, I don't know, whenever I remember you, the only thing comes in my mind is that patient that we had to do together for the tracheostomy when we had to convert it to a surgical tracheostomy, and that was the first and the last surgical tracheostomy in my life. Remember that day?
I have never forgotten that, Mazen, and it's always great to hear all you guys at King Faisal, and I definitely miss all of you, Nabil and everyone, and so just want to wish you all well. And right now I'm back in Canada, working at Vancouver General and St. Paul's Hospital. So enjoying practice and just wish you guys well.
Thank you very much, Gary. I'm back in the States also. I'm finishing King Faisal early June, and we'll just be visiting. Let me give the mic to Dr. Sanouri. So it's saying thank you, but I want to hear his voice. He's using his son's login.
The future doctor, inshallah.
Yeah, he's probably not there. Yeah, but he says thank you. So Ibrahim, we don't hear you. I'm going to mute you again. Any other comments from the audience?
I have a comment.
Okay, go ahead, Nabi.
I wanted to comment, you mentioned the percentage of patients that you can't ventilate, what was the abbreviation? Can't ventilate, can't oxygenate.
Yeah.
I have to say, you mentioned like the chances of this happening 1 per 10,000. I had the opportunity to have probably 2 situations like this, but I haven't done 10,000 intubations. But it is probably the scariest feeling that any physician would face is when you feel like the patient's going to die in your hands. One of those was on a sort of a satellite ICU in one of the hospitals in the U.S. where I was actually dictating a note and another intensivist was intubating, and I started hitting the nurses saying, let's get the trach, let's get the trach. And that was a patient we could not ventilate or oxygenate and had to have an emergency tracheostomy. It is a very difficult situation. Probably the most difficult that we face as an intensivist. Unfortunately, that patient did survive and did not have a hypoxic brain injury, but we've had 50% saturation for about half an hour until the patient was free. So it happens. I think it's probably more than that, 1 per 1,000. Each of us probably have one of those disaster stories sometime. And I think now better preparation probably leads us to less of this. I think that situation that I faced the physician was unprepared.
Exactly. Nabil, may I ask you on reflection, did you think or did the team think this going to be a difficult intubation case, or was the assessment inadequate to start with?
I think the assessment was inadequate. The patient was morbidly obese. The equipment that were available were limited, so we didn't have a bougie, we didn't have a trach, we didn't have the backup system. So any things that you mentioned on the checklist that should be there. I think if one would use that checklist, we probably would reach this 1 per 10,000 probably.
Certainly.
So I think having a checklist is the role is not to reach that stage.
So excellent. We're right on time. I have 3 things to add at the end. If nobody has any other questions or participation. The first thing is for all the experts around the world, if you have a presentation that you want to share with the rest of your colleagues through ICU Reach, feel free to contact me directly, and we can arrange for a good time for you. Usually we do our presentations at 1 p.m. in the western region of the globe, so people in the Middle East would be able to attend it. The second thing is at the end of this evaluation, this presentation, get a window asking you for brief few questions to evaluate this webinar and how we do it on ICU Reach. Please share any thoughts that you have with us, so we can make modifications on this to fit your needs. If you need any special topic that you need to bring to this platform, we can seek for experts in that topic and get it done for you. And the last thing, you will get a window for your support for the ICU Reach. With this, I would like to conclude today's webinar. Thank you, Dr. Hasan. Thank you for all the participants in this webinar.